Hey folks, welcome. This is Dr. Romy Chopra. I'm going to be speaking today about pelvic congestion syndrome and are we providing optimal diagnosis and treatment for this condition. I'd like to thank the NCVH and Dr. Craig Walker for inviting me to this seminar and online meeting. And I hope to cover with you today this condition, but also why it's underdiagnosed and how and why it's undertreated, and perhaps some of the things that we can do with it. You can always reach me via email at romy@mimithealth.com, or you can always reach out to me on either LinkedIn or any other social media channel where you can easily find me. The goal of my presentation today is to talk to you about pelvic congestion syndrome as a condition itself. How do you diagnose, treat this? One of the reasons I believe this is underdiagnosed, undertreated, is because there's a lot of misinformation around it. There's lack of data around this, and also there is lack of an understanding of how this can be treated. The lack of that data has led to less education about this. It has led to lack of reimbursement around this. And this is quite a challenging condition for women in the childbearing age who get this. So, as I said, very underdiagnosed, poorly managed. There's a lack of awareness amongst patients, amongst physicians who are treating. There's lack of reimbursement. There's lack of data around this condition. But what does the patient really want? The patient wants to be healthy, pain-free, and have a good life and live up to their potential. And when these women suffer from this condition, they poorly understand what is causing this problem, and at the same time, the providers who are treating this. As much as 10% of the general population of women suffer from this condition. In the ages between 18 to 50 years, 15% of women, over 10.5 million in the United States. As it's very prevalent, it's got a significant public economic toll, occurs typically after pregnancy, and it's very similar to varicocele in men. There's a lot of data around this. There's a lot of obviously challenges around this. Varicocele is reimbursed, treatment options are available, but not so much for this condition. The woman tends to be the center of the family. They're taking care of kids. They probably have a job. They have to take care of the families. And the burden is not just on the woman alone, but on the entire family and the entire ecosystem that she's caring for. Now, why does this occur? Typically occurs after pregnancy. The pregnancy results in significant pelvic venous flow, as you can imagine, with a fetus in there. That leads to the dilatation of the ovarian veins during pregnancy. And obviously, just like we see in varicose veins, there may be some valvular insufficiency, and that leads to continuous venous hypertension in the pelvis. So in a way, these are pelvic varicose veins, similar to the varicose veins that occur in the legs and raise pressure significantly. So we are talking about valvular insufficiency in the ovarian veins that then leads to venous hypertension in the pelvis. A lot of women will have concurrent issues with varicose veins in their legs. You may see veins coming out of the pelvic region, and in fact, a lot of them come to at least folks like me first because they may have varicosities around the vaginal area and the pelvic area and varicosities in the leg, in addition to all these problems that they may have. So the symptoms: pelvic pain, back pain, leg pain, aching, some abnormal vaginal bleeding. They may have varicose veins along the genitalia and into the leg. Vulvar varicosities are important. They may have some point tenderness in the lower quadrant, what's called ovarian point tenderness. And important is pain during and after intercourse. So this obviously messes up their personal life. It leads to a lot of anxiety, depression. They may have frequent urination and also challenges with their menstrual cycle. There's a dull pelvic ache that happens most of the time. And when they're laying down for a while, especially after a good night's sleep, it's almost minimal in the morning. And then as they stand up and the pressure starts to go up, it starts to get worse during the day. It's definitely worse by the end of the day. And then it gets exacerbated by prolonged standing and sometimes just by sitting for a long time. They lay down and the symptoms tend to go away. Deep pain with intercourse lasting for days is not uncommon either. They may also have intermittent sharp pain. They will land up in the emergency room. Most of the times the evaluation is negative because you don't examine the patient standing up. They're all laying down. By that time, a lot of this has gone away. There's anxiety and all those issues. But migraine headaches are also very common along with these symptoms. Now, a lot of them will not respond to the usual treatments. They may be on birth control pills. They'll be taking NSAIDs, and these are also ineffective because they're not really the cause of the pain, and they suffer for quite a long time before they land up getting diagnosed. I personally had many patients like this. They're all young. They're in the childbearing age. The partner is frustrated. The patient's frustrated. The family is frustrated. Obviously, the sex life is affected in a negative way. Now, if you look at the anatomy of the pelvic veins, the left ovarian vein, as it drains out, drains into the left renal vein, very much like we see in men and varicocele. If there is incompetence of the valve in this ovarian vein, there'll be reflux and hypertension into the pelvis. The same can happen on the right side. On the right side, it tends to go into the inferior vena cava. As the pressure goes up, there's dilatation, the valves get damaged, and that obviously leads to this. Has been graded. This data has been around for a while. There could be some degree of reflux, mainly from the left side, coming down partially or into, and even sometimes refluxing all the way across to the other side. A lot of these patients will land up getting laparoscopy, MRIs, other studies of different sorts, and these very large varicose veins may be seen in there. But the most important issue, or rather most important way to find this, is the clinical exam and physical examination. And the doctor who's initially evaluating this patient needs to be aware of this condition. A lot of the primary care physicians and a lot of the OBGYNs don't pay attention to this. And initially, you need to exclude all the other causes. So it's a diagnosis of exclusion almost. And I would not recommend jumping to this at the very first diagnosis. So rule out endometriosis, fibroids, pelvic adhesions, other urologic problems, and psychosomatic issues. You have to take the patient's symptoms very seriously, listen to them carefully, how they're describing it, because sometimes their family or the docs have said, hey, nothing's wrong with you, this is just hormonal, etc. They got migraines, anxiety, depression, they're stressed, and leads to problem. So the history, as detailed as problem, is good. Get all their records from everybody else, make sure all the other tests for everything else is negative. Examination of the vulvar region, some of the veins in the leg and in the pelvic and in the pelvis are important. As you can see in this slide here, patients will often have veins along the thighs coming out of the pelvic region, and it's not just important to look at the leg, but to see that they're coming in from the pelvis, especially if they're vulva, and then look at that as well. The pelvic exam may be normal. You do this in the lying position, but you'll see the varicosities outside. Look for tenderness. Obviously, all of them get an ultrasound. CT is also a good choice. MRI, MRV, all of these are important. Once it's excluded and it seems like they could be pelvic congestion syndrome, then obviously venography comes in. Pelvic ultrasound intravaginal ultrasound can show, transvaginal ultrasound will show you large varicose veins. Sometimes venograms will show you. Now, there's been a lot of discussion that this may be related with May-Turner as well, or other deep venous issues, and the both can be treated together. This also ties into the reimbursement issue, because now, and I'll repeat this a few times, almost every major carrier, if not all of them, consider this investigational. There's not enough data to show that this is worthy of their reimbursement. And as part of this, there was a movement for some time where this would be done in conjunction with treating, looking for May-Turners, looking at some of the deep venous issues, but some of the policies explicitly say, even with that, this is not covered. A lot of these patients may undergo laparoscopy, and you see large varicosities like this. MRI will show varicosities as well within these vessels and in the pelvis. You can see even with an MRV that this could be visible. And when the venogram is done, you can get back into the branch and you can see the large ovarian veins that tend to fill up. So initially, medical treatment rarely fixes it, but some have had progesterone or glutamine, but I don't. They're uncommon these days, not effective. Some have gone through hysterectomies and this, but again, not really recommended. But embolization turns out to be the procedure of choice. There are many different particles you can use, but you can go either via the jugular or the femoral vein, get down into the left ovarian vein, and then embolize it. We've done a combo of foam sclerotherapy with some coils, and the less the better. All of this can be done outpatient. Also important to go down and check with the iliac veins and see if there's no reflux from there into the pelvis and the pelvic veins, just as we do with when we treat varicoses. Obviously, there are some complications of problem. Less is more in the sense you don't want to overdo this, but infection is possible, but all very rare. Movement of the coils, some increased pelvic pressure for a week or two, bleeding, bruising, perforation of veins, but all very rare. I mean, these patients, they will have dramatic results. They're so happy when the pressure goes away. I've had women tell me they've not slept like this in a while. Their relationship with their partner has changed. They have no more pain during coitus, etc. So it can be very dramatic, and it's very effective for them. Some may take a few months before you see the symptoms, and it has no real adverse effect on pregnancy. But here is the major issue now. First is, yes, you could be aware of this. I've been treating this for years, but the challenge that comes into play is it's not reimbursed. And a lot of patients don't know that. A lot of the doctors don't know that. A lot of the systems don't have rigorous ways of checking beforehand whether or getting pre-authorization, etc. Patients can land up with heavy bills. So we are doing a disservice, one, by that not being aware, not this being diagnosed well. They've been bouncing around and miserable for a long time. But then when we actually find it, it's not covered. Now, we do all of this outpatient. We've found ways to, sometimes when the patient really wants it, create kind of a payment plan for them and give them some options. For trying to collect enough data so that there'll be some papers that can come out that can then lead to some evidence that will be supportive for reimbursement as well. So in conclusion, pelvic congestion syndrome is a very common condition. It's very underdiagnosed and very often misdiagnosed. It is important in your communities to raise awareness about this condition with the patients, with other treating physicians, primary care physicians, and also being aware of how this presents and what we can do. The treatment actually is very easy, done transjugular. You can literally be done within 20, 30 minutes, and they are outpatient procedure, and they'll be on the way home. The treatment is very safe. It's very effective. The complication rates are extremely low. And unfortunately, patients will bounce around a lot of places before they come to us. So at least if we raise the awareness, this can help. And the last part is the reimbursement issue. If done in a hospital setting, it can be very expensive for the patient. But in the outpatient setting, we do majority of work in an OBL. We get all the information before, we get the pre-authorization that's required before. Some insurances will cover depending on the plan, but if not, then we can create a plan for the patient. And oftentimes the patient will agree to kind of go in with this. We put them in a payment plan as well and go from there. And we're trying to get part of registries and collect some of the data that's required to really get enough evidence so that we can get this covered. With that, thank you very much for your attendance. Thanks again to the NCVH, Dr. Craig Walker, and hopefully you will have learned a lot from this, and hopefully we can solve this problem for all these patients who suffer from this. Thank you again.